Hi everyone, this is Dr. Alok Patel with Medscape. We're here at Digestive Disease Week 2019 covering all kinds of fascinating topics in GI. I'm honored to be talking to Dr. Reem Sharaya, who is the Director of Interventional Gastroenterology at Weill Cornell Medicine, New York Presbyterian Hospital. Dr. Sharaya, thank you for talking to us. We're going to talk about your amazing study looking at pharmacotherapy and intragastric balloons. Now we know that intragastric balloons can lead to about a 10 to 15% total body weight loss, but some patients regain weight after they kind of have the balloons removed. So your study looked at using drugs, but can you tell us a little bit about how you designed it and why you guys looked at what you did?
So thanks for having me, and that's a great question. So we know from the obesity data that there are a lot of patients out there who want minimally invasive procedures that give you benefit a little bit more than diet and exercise and medications, but obviously a little bit less than surgery with very low side effect profiles. And balloons fit that category. They're safe, they're reversible, and patients like them a lot. But what we do know from the FDA data is that patients lose weight because the balloon's in there, they have the restrictive feeling, gastric delay, food stays in their stomach longer, and they feel full. Once the balloon is removed, and all balloons have to be removed at some point, usually the 6-month mark, patients lose that restriction and start regaining weight again. And what we thought is that what about adding medications? There have been very small studies out in Europe looking at that, actually just one study out there, but it was underpowered to show any difference. So we thought we would look at our cohort of patients, add medications to those that want to have medications added to them and compare it to those patients that don't have any medications added.
Absolutely. And how did you guys decide which medications to use in the study?
So that's also a very good question, and it's at the discretion of the GI and the endocrinologist doctor, and also the patients, because there are 5 approved medications for weight loss, but there's also metformin, which is a medication used primarily for diabetes, but we actually use it for weight loss as an off-label use. And so we usually start with that because it has the safest profile. So that would be the first medication that we start, and then depending on the patient's profile, so what causes them to have weight regain. Some people have cravings, some people have nighttime eating, some people just feel hungry all the time. So we use different types of medications to stop that point in time that causes them to weight regain. And essentially what we found, which was great, is that patients continue to lose weight even after the balloon is removed. And
the ones with pharmacotherapy? The
ones with pharmacotherapy compared to the ones that didn't have any pharmacotherapy. Now, it's important to say that they both have diet and exercise and dietary contacts with dietitians, so they see a dietitian or a nutritionist every month, but the addition of pharmacotherapy just gave that extra bang for your buck, and they had a statistically significant weight loss at the 1-year mark.
At the 1 year. So do you think that the real issue here, I don't want to say issue, but the problem you guys are solving is kind of curbing appetite with pharmacotherapy?
So it's not just curbing appetite, but it's just showing you that really, in order to get sustained weight loss, it's not, you have to see obesity as a chronic disease. You're going to need multiple points in the patient's life, giving them some sort of treatment. So if it's the balloons now, but balloons plus medications, and maybe down the line something else, that's what we have to think of. And in order to get weight loss that's similar to surgery, that may be the combination approach of an endoscopic bariatric treatment plus medications will give them that option.
Absolutely. Now, I'm glad you mentioned that balloons are becoming more popular. We know that they're safe. How do you think that your study is going to affect the future? Do you think we're going to get into an era of new standards with balloons and pharmacotherapy, or would you like to see GI doctors looking more into it?
So we believe that obesity is a GI disease, and it affects so many things within the GI tract, and it's one of the most common causes that patients see, and it should be something that every GI doctor should sort of see the patient, see that their BMI is above 25 or BMI above 30, let's offer them some sort of treatment. And they can start with balloons, but have the option of sort of thinking like, maybe I need to add medications there to help them augment their weight loss. And if I can't do it, or I don't feel comfortable do it, then partner with an endocrinologist or an internal medicine doctor that can give medications.
Because medicine's a teamwork.
Exactly.
Now, so the last question I got to ask you is, I saw that your study looked at patients at the 12-month mark. Are you guys thinking about looking further?
Yes, for sure. I mean, the 12-month mark is usually sort of the easiest data to get, and then usually after that, patients peter off. But I think the ideal study, which is what I'd ideally like to do next, obviously keep following this cohort longitudinally and see what happens to them, but also do a prospective trial, sort of giving medications versus not in a more rigorous fashion, because this study obviously is retrospective. It was based on the patient and the doctor, whether we gave the medications. So you want to see this sort of prospectively, and so then you have hard endpoints where you can sort of argue that this should be the standard of care.
Absolutely. Dr. Shriya, thank you so much for talking to us.
Thank
We're
you.
looking forward to seeing the results in the future.
Thank
And
you.
changing the standard of care for the teamwork of medicine.
Thank you for having me.